So for the next 20 minutes, I try to go over some of the projects that we have had at Mayo Clinic, a couple of projects from a colleague of mine, and that was done in the field of artificial intelligence in critical care medicine. So as you see, I have a lot of disclosures. None of them pays me money, but they pay for the research that I do. Some of them are industry, some of them are other universities that we collaborate, some of them are federal government. And this is very important notion that AI particularly needs all the stakeholders. You cannot do AI alone. Yep.
Slides, please. Slides on the screen.
Yep. So these are the disclosures. For example, I work with Google, Philips, and the company in Italy, UCare. And also we have a project with NIH. It's called ADART that I'll describe it later to the audience. I will not talk about Gen AI as this is a whole new topic here that we are working on, but we will talk about acute kidney injury particularly and artificial intelligence continuum. So if you recall, it's pretty old. In 1956, the IBM RAMAC computers were really kind of large. They were 10 tons of equipment. They costed about $31,000 per month, and they only had 5 to 10 megabytes storage. Now, moving forward in 1985, the supercomputers had a significantly larger memory, 32 gigabyte, which is significantly more. They were smaller, but still 2.5 tons of weight, and you could put them in a small closet, but you had to kind of have a lot of space. Now, all of us have computers that are stronger with the larger memory in our pockets, and this has allowed us to be able to use this science in order to make the field move forward. There are a few things that this particular science has helped us so far. So public health, for example, is an important feature. So you remember in the COVID time, there was a lot of information provided to providers and patients. So all the contacts were able to be monitored, and AI was underneath of all those information that was provided to us. A lot of these AIs were able to predict what would be the incidence of COVID in a certain area. Now, Professor Herrera's work on pathology or radiologists, they can use AI in order to recognize patterns in pathology samples or images. And this has made significant progress in the last few years. We are currently using AI in clinical trials. We are running several clinical trials. These models allow us to identify patients, recruit them, and monitor them appropriately. We collect data using AI. I'm not paying coordinators as much as a few years ago because AI is able to screen patients for us much simpler and much more accurate. We are using it in patient care. I'll show you several examples of AI projects that we are currently doing. And I noticed that one of our young colleagues here presented CKD, mineral bone disease, which is an amazing project. I think that this is being spread across the field that we are working. And also AI is used in order to manage the flow of our patients in dialysis units or hospitals or outpatient clinics in order to make sure that patients' waiting time is the least, the efficacy of our work is the most, and provide better care for our patients. In the near future, these models are able to coach us. They can help us to provide answers to the questions that we don't have it right in our mind. Whenever we have a conversation with our patient for a disease that they come in with a syndrome that is very rare, these AI models are able to hear conversation between patient and doctors and provide us information regarding to that disease and the management of the disease. They are able to provide us clinical notes. This has been implemented in Mayo Clinic last couple of months. So when in outpatient clinic, you have a conversation with your patient, not only you have two notes, one, a summary for patient with the language that they understand, and a summary for your notes. So, and this summary bullet pointed note that you can put it, cut and paste it in your notes and is a billable item. And in the near future, it can help us to teach our younger generation. It can provide some feedback, it can provide some simulated cases to show how the cases should be managed in a realistic fashion. So there are different types of artificial intelligence. These are machines that mimic human intelligence. As you know, human intelligence is very wide. We can think out of the box. We can improvise. We can manage things that they've never happened before. The problem with these AIs is that they have a very narrow intelligence. They only can manage issues that they have experienced in the past. They cannot manage issues that they haven't ever seen. That's the difference between intelligence in artificial intelligence and human intelligence. But artificial intelligence includes machine learning that are algorithms that can help us to identify answers to certain questions. Our young colleague mentioned supervised and unsupervised machines. There are some advantages to them. For example, learning the data directly from data set, working with variety sizes, so small data set to very large data set, they can work with, and then do not require a lot of equipments. You can do it with a simple computer. They do not need supercomputers. They have superior performance in comparison with the statistical models, and they can also kind of predict the nonlinear variables. The problems that they have is that they have some of these similar problems that the statistical models can provide. They lack transparency, so they are in black box. So when you tell them the prediction of acute kidney injury, for example, the clinicians, they do not know what variables was used in order to predict acute kidney injury. And that is the problem that doesn't allow us to trust these machines as much. And also they sometimes easily they overfit, so they show better performance in data than patient care. Deep learning is several different models working together in order to provide very advanced evaluation. Well, we have an AKI prediction model that we developed with deep learning from Google with area under curve of 0.96, means that it is extremely accurate. And this is work in progress. We are implementing that in clinical practice. They are extremely powerful. They can see what we cannot see. So they can train the variables that they are moving, but we cannot see with naked eyes. So for example, if your patient has a heart rate that goes from 60 to 65 to 70, unless it gets to 120, we don't pay attention. But machines know it. Machines can pick those up and let us know in advance that this patient is crashing. So please be careful. They can also transfer learning, means that if I develop a model in my data set, it can work in data set that you have. So that is the advantage of deep learning models. They can incorporate different data types, including imaging, in unstructured data, including your notes. The problem is that they really need very large data sets and they really need very strong infrastructure. The computers that they can develop deep learning are different from the computers that they develop other models, machine learning models. And also they have no transparency. We know that each of our patients, each of us have some data around us. Some of them are electronic medical record. Some of the data is coming from our watches and our cell phones. Some wearables as well. Some of them exist in governmental data sets. This creates a digital health aura. So we have data around us that can be used in development of different models. They can be used in community applications. For example, we can, for acute kidney injury, we can identify risk of patients for acute kidney injury. We can recognize when acute kidney injury in a community happens. We can tailor our responses and encourage recovery. Same thing for a hospital. A lot of work is being done in a hospital acute setting or ICU. We identify acute kidney injury. We predict acute kidney injury. We can manage acute kidney injury using these models and improve kidney function. I'll show you some examples on after hospital, how these models are helping us to manage patients after hospital. And this is a part that is unfortunately missing in a lot of practices, and these models can help us to achieve that. So moving to some of the applications, some of the projects that we have done in the past recent years. You know that acute kidney injury definition is based on increasing serum creatinine and decreasing urine output. One of the major problems is that a lot of patients do not have baseline serum creatinine measured. So we estimate based on serum creatinine using back calculation from MDRD formula, or we use the first creatinine that is measured in the hospital setting. So we developed a model using gradient boosting technology, machine learning technology. We used 44,000 patients at Mayo Clinic that had measured serum creatinine as a gold standard. And we asked the machine, can you predict what is the baseline creatinine? And what it did was astonishing. It was amazing because if you look into x-axis, one means that if you are at one line, means that the predicted creatinine and measured creatinine were the same. The more deviated you are from that means that you are more, you develop more errors. The brown lines at Mayo Clinic data set was exactly cut off by the model. As you can see, there is a significant overlap with one line. And then the blue lines are MDRD back calculation, which is significantly deviated from one. We validated that in mimic data set and exactly found the same thing. The good news was that MDRD formula back calculation resulted in 41% misclassification of patients in acute kidney injury. However, this model decreased that to only 15%. Still not perfect, but significantly better than what we are currently doing for patients who do not have measured creatinine. Then we developed this particular software in order to see patients appropriately. So this is a map of one of our ICUs, and each cube is basically a bed. And if I hover my cursor on one of these beds, it opens that bed and provides me some information. I'll tell you what these informations are. So first of all, name and medical record number, age and gender. There are a bunch of boxes on top that modify, so Meow's score, SOFA score, COVID, if they are positive or not, palliative care score, and get with the guideline score. So we can add more models on top. It gives you kind of a score of those variables. This line has all the equipments that are using. For example, from left to right, it has a vasopressor, patient has ECMO, intra-aortic balloon pump, patient is on dialysis, the kidney sign, patient is on mechanical ventilator and is monitored closely, and the patient is DNR and is infected, so he's on antibiotics. Also provides some information about organs. This bottom line changes color from white to yellow to red based on the variables that may need attention urgently or emergently. And finally, length of stay, and if they are in progressive care unit or ICU care status, these patients. If I double click on that box, it opens this particular page, and this gives me significantly more information about where we are and what we are doing with the patient. Again, going back to this, if I hover my cursor over this red circle, it opens a table for me that tells me the patient has acute kidney injury stage 3 based on what criteria is urine output or serum creatinine. And therefore, I can know if patient have acute kidney injury or not. And as a matter of fact, if I go back to this map, with a click of a button, it removes all patients who do not have acute kidney injury. And I can see patients with acute kidney injury only. So what I do in the morning, I go to all ICUs, I click that button, I only pick up patients have acute kidney injury and we are not consulted yet. So I review those patients, I provide some recommendation to the providers, critical care team in ICUs, and this has resulted significant changes in their plans and hopefully kind of improvement in outcome. This is another project that we did for prediction of acute kidney injury. This is a project that we did with a company in Philips Research North America. We alarm individuals, clinicians, that patient has high risk of acute kidney injury. The yellow line is when patient already has acute kidney injury. So all the alarms generated after that is blocked. So they don't get many alarms. So the performance was reasonably good. Area under curve was 0.77, which is considered a fair for all AKIs. And for moderate to severe AKI, similarly, the performance was reasonably good. The issue is that when you go from 24 hours before AKI development to the time of AKI development, area under curve improves. When data gets more and more abundant, then the performance of these models improves. So around 9 to 10 hours before that area under curve reaches around 0.8, which is really good prediction model. So it gives you about 10 hours to predict and avoid further damage or injurious interventions that patients can encounter. The variables that we use for all AKIs included average urine output and creatinine on the top. So the most important variables for all AKIs were acute kidney injury and creatinine. However, for moderate to severe acute kidney injury, volume balance, now the pathophysiology of acute kidney injury came to the variables that was used by the model. So fluid balance was really important. Creatinine and urine output still was a very important factor as well. Now, this is a model that shows the transferability of this model, generalizability of this model. This model was developed by a company in Italy, but we validated it in a Mayo Clinic data set. This is to predict persistent severe acute kidney injury. These are patients who have acute kidney injury stage 2 or 3, and we can predict if that acute kidney injury is going to last more than 72 hours, or patients need to die within 48 hours, or patient need dialysis within 1 day. These are all important information. If you know patient has very high risk, you may want to decide to dialyze these patients earlier rather than waiting 72 hours for them to become very sick. And indeed, as you can see, area on the curve at Mayo Clinic was 0.97. Basically, perfect model to predict persistent severe acute kidney injury. And these are different, all lines are different definitions of baseline serum creatinine, but performance of the model was very good. This model was, again, developed in different data sets, was validated in our data set. Performance was even better in our model, in our data set than the original data sets. Now, nephrotoxicity is something that we all deal with, and it's very important. As you know, vancomycin is one of the most common antibiotics used in the hospitals. And unfortunately, only 40% of our patients land in the target level of vancomycin, trough level vancomycin, after 4 or 5 doses. A majority of them are underdosed or overdosed. Overdoses causes toxicity. Underdosing causes inefficacy of the treatments. So we have a model that can predict overdosing and underdosing, and the performance of the model, when we get closer to the time of trough measurement, third measurement improves to around 0.8 area under curve. So this is an example. It's a female 52-year-old BMI of 25, estimated GFR 64, serum creatinine 1.2. The original dose was every 12 hours with loading dose of 1500 milligram, maintenance dose of 1500 milligram, and trough level was indicated patient is intoxicated. So it was very higher than what the target level was. When we used the model, we were able to predict that at the very beginning of treatment, that patient is going to be overdosed. And this allows us to change the prescription. The problem was that we asked all pharmacists, would you use this model? They said that we love to use this model. However, when we gave them cases, they always went with what actually they calculated. They didn't trust the model as much. So we have to kind of work on human factor here. This is a trial by a colleague of mine, Perry Wilson from Yale. 5,000 patients were randomized in 2 cohorts to manage nephrotoxicity. And one was directed by AI, one directed by clinicians, the standard of care. So AI model indicated if patient has acute kidney injury and if patient is on RAS inhibitors, NSAIDs, or PPIs. And also kind of connected the patients to individual doctors to the order set. So what, as you notice here, NSAID, discontinuation of NSAID was not different between the 2 arms. We are really sensitive. When patients have acute kidney injury, we stop NSAIDs anyway. So machine was not that helpful in that. But there was a significant difference in RAS inhibitors and also PPIs. The clinical benefit, however, was only noticed on PPI discontinuation. And RAS inhibitors, as you know, they are not
Dear
inherently...
doctor, your time is up.
I need 5 more minutes.
Open the slides, please.
So PPIs, as you know, RAS inhibitors are not inherently nephrotoxic. They are actually nephroprotective. They change GFR, but they are not nephrotoxic. So they didn't see any clinical benefit of that. But PPIs could lead to interstitial nephritis, and that was the difference that you can see. There was no difference in other clinical outcomes or safety outcomes in the trial. CAT-AKI is another trial, but same group. They compared standard of care versus kidney action team. Kidney action team included a doctor and a pharmacist. And what they did was they were receiving all the alert and providing some recommendation about potassium acid-based management, volume management, diagnosis, and medications to the clinical teams. So 4,000 patients randomized, 2,000 patients in each group in this study, and then primary outcome of acute kidney injury progression, dialysis, and mortality in 2 weeks was not different between the two arms. However, there were significantly more completed process of care differences between the two arms related to acute kidney injury. These were mostly focused on general recommendation, also medication changes. So it's important to have a pharmacist on board. If my impression is that if there was a significantly larger group, we could have basically used a different tool. Now, this is a very important project. It's an NIH-sponsored project. We looked into 1,600 patients that were on dialysis to predict intradialytic hypotension. You know, that is very important to know if patient is going to have hypotension. These are all AKI patients. Any episode of hypotension would lead to worse outcomes. So this model, we identified patients who had intradialytic hypotension, 15% of these 1,600 patients, and 85% didn't. So the model that we developed, the direction goes from 2 hours
Dear
before.
doctor, your time is up.
This is very annoying. So the model went from 2 hours before to the time of hypotension. As you can see, the performance of the model was 0.73 at the very beginning. I cannot advance it.
3 more minutes,
Thank
please.
you. So 0.73 at the very beginning and 100% at the time of hypotension. The 45 minutes before hypotension arrived, you could know patient is going to have hypotension. And you could intervene with that as well. And as a matter of fact, if you look into hypotension, time to hypotension 2 hours before, there's a good separation between those who had hypotension versus those who didn't. And at the time of initiation of dialysis, as you can see, about 30 minutes before initiation of dialysis, even you could separate these two groups. So you could pay more attention to those who have higher risk of hypotension. Indeed, we took advantage of that. For the first 15 minutes, we identified those who are at higher risk. And based on that, we identify high risk versus low risk and provide actions. The action that we provided was using reinforcement learning. So in reinforcement learning, some clinical scenario or simulated scenario provides a state, and state would lead to some sort of interaction or action by clinician or computer. That would lead to action that changes the state of a patient, and that would lead to state number 2. State number 2, and this reiterated many times, thousands of times. Each time patient gets better or worse. And based on the changes that patients make, the machine learns how to improve the patient outcome. Now, we used the simulated data of 25,000 patients and compared it with the 1,600 patients that we had. So we had in silico trial of a 25,000 patient simulated patient with that real 1,600 patients. And we did a trial to see what are the intervention changes. As you can see, 80% of patients who were clinically managed didn't have any change in their practice despite having hypotension. But the machine did a lot more intervention. Most of the intervention, they increased ultrafiltration, IV fluid, or pressors. And also machines had significantly less order to decrease ultrafiltration. At the same time, intradialytic hypotension was almost 1/3 by the machines in comparison with humans. So improved significantly that, and 95% in comparison with 64% of the machine managed patients achieved the volume targets. So it works really well. The last project is watching patients after discharge from the hospital. So this project, we identify patients with acute kidney injury, we educate them, we send them home with a tablet, with blood pressure, vital sign measurement, and it's monitored by some nurses, and we graduate patients 3 months after discharge. And they have some protocols for their management. As you can see, for the interest of time pass. And so a lot of patients had some diuretic changes. Some patients didn't have any changes in their management. And ED referral was also noted in 5% of patients based on what nurses had as a protocol. There was no difference in based on characteristics between those who were in control versus AKI remote patient monitoring group. Our primary outcome was hospital and ED readmission. There was no difference between the two arms. This is just a feasibility trial, so it was a very small sample size. We saw a trend toward less hospital admission among patients who were managed by remote patient monitoring. And we saw more ED presentation when they actually were in emergency department. We think that by sending patients to emergency department earlier, we could avoid potentially hospital admission. And this can be achieved by larger sample size that we are working on at the moment. Next step on this project is that we are using on large language models, generative AI, in order to communicate with patients appropriately. We are using machine learning to predict who is going to crash and what they need to be done. We are using smart medication bottles to dispense different doses of diuretics based on their patient's weight, oxygenation, and blood pressure. And so hopefully these can help managing these patients a little more straightforward. So using AI for clinical advancement is inevitable. This is coming, so we should probably kind of get to learn it at least. The volume of work on AI and critical care nephrology has been incredible and growing. And the digital health in acute kidney injury continuum needs further development, assessment, and implementation. So all hands on the field needs to be used. It is important to, again, recognize that there are many stakeholders need to be engaged. Industry, federal governments, companies, universities need to collaborate. Any collaboration from our colleagues in Egypt, ESNT, would be really appreciated. We would love to work with you on development and validation of the models. If you have a model, we'd like to validate it in our cohort and vice versa. And again, collaboration is essential, and it takes a village to make this field to move forward. I thank you for your attention.